All right, we're just gonna give it a few seconds here, let everybody join us, and then we'll kick it off. All right. Okay, on behalf of the American Heart Association, I would like to welcome you to this panel Q&A session. We have some questions for our panel to get things started, but also welcome your participation by submitting questions as well. You may do so by using the question features on your control panel. You may send in your questions at any time. To access live closed captions, please click on the closed caption button found on your screen. All sessions will be recorded and available in the coming weeks.
Thanks so much, Jennifer, for kicking us off here. So we're very fortunate to have Dr. Meyers and Dr. Yaranov here this afternoon to answer your audience questions, as well as kind of have a discussion with us and some questions we have as well. Really kind of trying to understand how you've built your heart failure programs and what you see in the future for advanced heart failure care. So again, if you'd like to submit questions for them, please do so. By going into that Q&A box. But I'd like to kick it off here and to start, I'd just like to ask you guys, how can hospitals work to overcome some of the racial and gender barriers in the referrals to advanced heart failure therapy?
Dr. Meyers, you want to start?
Sure.
Go ahead, Dr. Yaranov.
Right.
You take this one.
Sure. Okay. First, I think the first and foremost is, for the hospital is to acknowledge that there's a problem. And I think that's where, the actual work starts there, without realizing that, you have definitely a racial and gender gap there, without, knowing it, it's going to be impossible. And then second step is, be very frankly and understanding where you practice medicine and where your hospital is located. I'm in Memphis, Tennessee. If I was, in this delusion that all my patients, are taken care of the same and have the same access, I wouldn't be doing what I'm doing right now. So I think it's critically important to understand break down those barriers and make sure you understand that, what our actual barriers are. Distance to, whether it's distance to the hospital, access to insurance, access to coverage, access to transportation, you name it. And once you realize what the barriers are, out of a sudden you realize some of those barriers are just perceived barriers. Obviously in the heavily underserved areas like mine, insurance comes as a big problem, and African-American population access to insurance and carriers. Having a very strong financial coordinator helped us a lot. We have a great financial coordinator here who works with all the different insurance carriers and gets patient insurances in a very fast time. And then you name it. I think it's just it starts with acknowledging all the fact and looking at the breaking down those barriers.
I really agree with you. But I also think that we're in a really tough situation in the United States right now. I mean, we've got 50% of the counties in the United States do not have a single cardiologist. So unfortunately, we are, kind of an elite group, and we're kind of concentrated in big metropolitan areas for the most part. And that is a real concern. Because I think that it's tough to get the message out there to the communities. And sometimes people are dying of cardiogenic shock and they're never getting referred. They come in for heart failure over and over again to little community hospitals. And I think that the message that this is so serious and these repeated hospitalizations are really concerning. The concern doesn't get escalated. But then put that against the background of the fact that, if you look at the New York Times Medicaid maps, and they were just published a couple months ago, if we cut Medicaid further, this is really, really going to make these disparities more pronounced, not less pronounced. And I think, and that to me is very, very frightening.
Yeah, I totally agree with you.
Yeah, and I think my next question was, you touched on it a little bit, Dr. Yaranov, but, talking about uninsured patients and, what strategies you have in place to assist these patients. I think it's a question that I get asked a lot is, what can we do for these patients if they don't have insurance? If you have any other strategies, I know you mentioned a financial coordinator, but anything else, that you guys do to try to get those patients insurance if they don't have it, so you don't need to turn them away.
Let me, I'll underscore that, strength of your financial coordinators, your ability to get those patients on the insurances, and whether it's a marketplace, whether it's state Medicaid. I think the biggest part also is, we are a rural center that freely accept Medicare coverage and does work real hard with your state and actually 3 different states to assure that those advanced therapies are covered, because I'm very well aware that there's multiple different states out there that would not even cover advanced heart failure therapies on the Medicaid insurance, although they provide Medicaid. So I think that we have to do a lot of work around the country, lobbying, that those therapies should be covered by those type of insurances.
I think it's just such a shame that, I mean, I'm one of the few cardiologists in the United States that have actually practiced in Australia, where we have a 2-tier healthcare system. So we never there saw patients that were completely uninsured the same way that we do in the United States. And I think, we go to great lengths at OHSU for our patients. It was a huge issue when we see a fair amount of undocumented individuals who come from other cultures. And, before our Medicaid expansion took effect here at OHSU, we were actually going to foundations, and we were able to get some compassionate, insurance for these people. But, my God, I think we just really have to ask ourselves, is having a basic level of healthcare available to everyone, does this support a healthy population, people who are able to go to school and get educated, people who are able to contribute, or are we creating a class of people who just are never going to get ahead because of their bad health? And I think that's a really big philosophical question that we have to ask as a nation. And right now, the answer seems to be no, which troubles me to no end, because if you're sick, how are you going to go to school? How are you going to go to work? How are you going to manage your family? It's such a crazy situation.
That's a great point. The next question we have is, what do you see coming in the future to aid in identification and management of advanced heart failure patients? I think whether that be, AI technology, other devices, if you could just speak to kind of what you see coming in the future.
Well, one thing that I think would be a really cool development would be a nationwide shock system. And I would love to see that, so that people could use and become aware of the new sky definitions, that they could start looking at those charts that, I think, Dimitri, I think you presented some of the sky data, and that they could start becoming aware of those definitions, and that we could have a hub and spoke system for those cardiogenic shock patients, so that we could get them to care earlier. Because, it used to be that, cardiology was all about door to balloon time, but in some of these patients, it's about door to support time. And I think this is a really important new paradigm that I hope that could catch on. Just like in our trauma network, we have hub and spoke systems. I would love to see that for cardiovascular care, but I also want to just put it into, cardiogenic shock is not just about mechanical support. It's about ushering someone through a critical multi-organ disease. And it's not just about devices. It's about a whole way of ushering a patient through a very complicated illness trajectory.
I totally agree. I think that, there are quite a few things that are coming in the future, and hopefully are coming in the future. Data dissemination and education is paramount, for our success. I think that we're doing a terrible job about educating our communities, or, the data travels so slow. You talked about this article that I read myself as well, in the British Journal of Medicine, about cannabis and a risk of cardiovascular disease. I don't know how many years it will take us and for patients to learn about it. The same about all the know-hows. And I think we just, there has to be a better way of, penetrating the communities, both professional and patient communities. And two, certainly we are working on the newer devices and therapies and heart failure. We talked a lot today about the burden to caregiver, about the burden to families, and hopefully as we evolve as a field of advanced heart failure, we create therapies that may not be as burdensome with regards to healthcare teams. And hopefully they will become, nowadays, I remember back in time, we were talking about not offering stent to someone who is non-compliant and won't take their antiplatelet medications. There was the same case with HeartMate 2 device. And then, eventually right now, no one leaves the hospital without the stents. Stents are so great. And, our field also evolves. We're just trailing behind because we're end organ disease state. So, I do think there is quite a few things in a pipeline on the device and medical therapies that will evolve our field as well and make it more accessible to others.
Thanks. That's a great answer. And I think another one we have here in the chat was, how effective is using infusion centers for heart failure patients? Do you believe in infusion centers to manage and reduce readmission rates?
We do have an infusion center here. I do, and I remember infusion is not just diuretics anymore. I mean, now that the guidelines have changed on things like iron infusions, I think this is becoming a more common practice for heart failure patients who are often anemic and often have some degree of renal insufficiency. So I'm using them a lot for iron. I think, it's I think it's our infusion center still is sort of struggling with the idea. And I also think the infusion center, if you could give someone 6 hours of diuretic and then send them home, there's still the issues of what are their electrolytes going to look like the following day. And, the idea of having them come in and infuse and then come in the next day and get labs, then there's a delay and you have to check the labs. Like I'm all about like point of care testing. I think there needs to be more point of care testing for electrolytes to make this more patient friendly. And I think if we could combine that with things like, Furoscix kits that patients could have administered in their home, that might be easier. So I still use infusion clinics, but I think it sounds so great, but in practice, there are all these little difficulties with it. And, you don't want somebody to go home. They're going to go home and diurese for hours after you do the infusion. And you don't want them to have a potassium of 2.5 and arrhythmias the next day. So it always makes one a little, there are all these practical issues that end up creating difficulties. What about you, Dimitri? Are you
I'll
using them?
totally echo your iron story. I have the same affinity to it. I always try to there's a lot of initiatives about readmissions in a heart failure space, and we always encourage thoughtful and intentional use of those infusion centers. If you just use infusion center to just pour diuretic in those poor patients and get them out of in the hope they're not going to end up in emergency room, that's where we see this flip in this data where it actually those hospitals that have done it too well back in time increased the mortality in those patients. So I do think there is definitely a role, but there are just all those caveats that you explain. If you intentionally use it and your system is well set for this intentional use, I'm all for it. If you just use it as, hey, let's bolus this 80 of Lasix to just keep them out of the hospital, you'll get in a lot more trouble than you'll do good for your patients.
We have a program here at OHSU, which is kind of cool. And it's called Hospital in the Home, where the patient is admitted very briefly, a care plan is organized, and then they go home with video cameras, monitors, nurses will come every day. And, that may end up being a more because most of our patients have low blood pressures, and giving them, very high dose of diuretics all in one go may not be tolerable for them. So the hospital to home is really cool because this can be then shifted to the patient's own home. They can use their own bathroom while they're being diuresed. They can have their own food, their refrigerator. I mean, and they can have all of that electrolyte monitoring, and which can be really, really fantastic. So it may be that developing more of those types of interventions around diuresis and volume overload is going to be, it can be developed and may be more practical in the long run.
It's very futuristic.
It's cool.
I love it. Yeah, I love it.
Yeah, it's cool.
Yeah, thanks for sharing. Well, that is about all the time we have for today. So I want to thank you again, Dr. Yaranov and Dr. Meyers, for sharing your knowledge and your valuable opinions today. And thanks to our audience for all your participation. But that concludes our Advanced Heart Failure Summit for the day. And I'd like to thank you again for attending this event. You will receive a post-event survey with some questions to help us as we continue to develop future education. So I would really appreciate it if you took the time to complete that. And again, this initiative was presented as part of our Heart Failure Education Initiative that's supported by Abbott. And we look forward to hosting more educational events around this initiative and encourage you, again, to visit that website we shared in the beginning to learn more. Should you have any questions or feedback, please feel free to email me. My email is on the screen here. But again, I'd like to thank you for your attendance, and I hope you all have a wonderful weekend.